Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I am a clinical professor in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Today, I have the privilege of interviewing Dr. Matt Fernandez. But before we get on to the interview, I wanted to thank all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes really helps others find out about chiropractic science. So, if you like the show, please take a second and write a review. It will support chiropractors everywhere. Here's a review from the Chiropractic Science website from Dr. Robert Sheely, who says, I just finished listening and wanted to tell you how wonderful it was to hear a review of Dr. Christine Gertz's research experience. Dr. Smith, your podcast should be required listening to all practicing chiropractors. I actually believe the general public would find your podcast of great interest, as many want to find out more information about chiropractic. Well, thank you, Dr. Sheely, for listening and sharing your feedback. If you'd like to leave an audio review that I might include on a future episode, just connect on Facebook or send me an email. Please consider making a contribution to Chiropractic Science to keep these podcasts going. You can do so on our website, chiropracticscience.com, by making a donation. All right, on to the podcast. Well, let's get on to the interview with Dr. Matt Fernandez. Matt is a registered chiropractor in Australia and is currently a senior lecturer at Central Queensland University, where he teaches and supervises students in the Master of Chiropractic program. Prior to his CQU appointment, he was a lecturer at the Department of Chiropractic at Macquarie University. Matt is very passionate about research, and following the completion of his PhD at the University of Sydney, he now leads research projects and supervises research students. He also regularly presents his research at conferences in targeted areas that advances the knowledge and understanding of chiropractic through physical activity, exercise, and patient education interventions. Matt is also a member of the inaugural Carl Fellows. Well, Dr. Fernandez, thanks so much for coming on the Chiropractic Science podcast.
Hi, Dean. Thanks very much for having me. It's a pleasure to be here today and have a chat.
Yeah, well, I'm really excited. This gets into areas that we're both, keen on talking about and doing research on. So I'm really looking forward to our discussion today. And I would just ask you, as we get started here, I always ask this question of every guest, and that is, can you tell us how you became interested in becoming a chiropractor?
Yeah, happy to chat about that. I guess towards the end of my Bachelor of Sports Science degree, the undergrad degree, I was kind of unsure about what the next path would be for me. I had been competing in swimming events and also surf life saving events and also coaching in that space as well. So from my sports science degree perspective, that was really advantageous from a coaching perspective and also personal. But I was really open to other parts from a career perspective. And it was around that time that my dad had reminded me that my brother had suffered migraine headaches at school. And this was spectacularly sorted out with chiropractic. It was really impactful for my brother, but also for my family. And we all know as chiropractors what a full-blown migraine can look like. And I quickly remembered that my brother would come home from school early because he was sick. Other times he wouldn't make it and he'd be vomiting on a bus on the way home. And before the success of chiropractic for him, he'd had less success with medication, massage and acupuncture. So that was pretty impactful. And look, at the same time, as we were finishing up the undergrad degree, there were naturally students that were looking to go on into further study and some were looking into physio. And I had a couple of good friends who were looking into chiropractic. So chiro seemed to be the road for me, and we enrolled into Macquarie Uni and got a little bit of advanced standing with a couple of subjects in the sports science degree, and basically went on to complete the degree over the next 3 years. So yeah, that was more or less how I got into it.
That's awesome. Yeah, it does seem that so many of us have these personal experiences, and teaching at an undergraduate level, I see the same, whether it's people that are interested in getting into PT or chiropractic or med school, they've had those personal experiences. So I appreciate you telling us about that. Well, can you tell us, once you're in chiropractic school and let's say, getting close to the end of that schooling, what happened next? Did you go into practice, or were you immediately interested in research? Just maybe tell us about that transition from chiropractic school to interest in research and the PhD.
Sure. So after uni, graduation, I did practice for several years, and most of it was in a multidisciplinary clinic. So this was an awesome experience for me because I got to work with physiotherapists, massage therapists, and a little bit later EPs, exercise physiologists, and podiatry. And I was exposed to a lot of techniques which I didn't necessarily know about during my time at university at Macquarie. And so I got exposed to things like spinal mobilization, neurodynamics, and also the McKenzie method, amongst others. But at the same time, as we all are early on when we start in clinic, we're really inquisitive. And I sort of reflect back when I was in clinic at the time there, and I was really exposed to a lot of chiropractic techniques as well as an associate, like things like applied kinesiology, NET, and in particular cranial techniques or cranial dental, cranial orthodontic techniques. And look, all of these were really fascinating, and I went on to use a few of these and learn a little bit more. But at the same time, I've always had this interest in exercise and manipulation, and really that's what resonated with me. So I was a sessional staff member at Macquarie, and when you're a staff member, as you know, you get good opportunities to hear many guest speakers. And at the time, I remember there was a research seminar series, and there was a researcher from Sydney University that was presenting data on twin studies. And I distinctly remember it was a systematic review on the topic, where they looked at the potential impact of genetics and the environment and epigenetics as we know it. And they were looking at back pain and other musculoskeletal problems and the influence of genetics. And they also talked about the relationship of low back pain and chronic diseases, including diabetes, sleep problems, heart attacks, cardiovascular disease, mental health, and how it resonated with back pain. And more or less, this work hadn't really been done. So obviously, these are huge public health topics, and they were of great interest to me because we know exercise or physical activity can impact those. And during that talk, I got the sense from the speaker that these ideas or projects were kind of ready to go and they just needed someone to do it. So I met up with the speaker, who was Dr. Paulo Ferreira, who's now a professor, and he was leading this pathway. And, fast forward a few conversations, I was successful in getting into the PhD program because I'd done a little bit of publishing prior. I was successful with a PhD scholarship from the generous funding from COCA, which is now known as Chiropractic Australia. And off I went on a new journey. I started at Sydney University. I started my PhD at the Department of Physiotherapy. And I had 4 supervisors. Paulo was the primary, but I also had a really hot team that was made up of Manuela Ferreira, also the Dean, Kathy Ripshorgi, and someone who's well known to chiropractic, Dr. or Professor Jan Harvickson as well. So I had a really good team, and I went on to publish 5 papers in my PhD. 2 of them were meta-analyses looking at sciatica or radiculopathy, and we looked at the impact of surgery versus physical activity for sciatica, and then also we looked at specific structured exercise compared to advice to stay active for sciatica. And we followed up with the twin studies as well. We did a number of observational studies. We looked at low back pain and associations to heart attacks, depression, anxiety, and also low back pain and all-cause mortality. And that study, we titled it, My Back Pain is Killing Me, and it actually generated a lot of media interest because, as we know, the media can sensationalize things and started printing out things like, if you have back pain, you're going to die earlier. But of course, we know this is not true. The proper title should have been, poor health sees us, dying earlier, but, that wouldn't have sold any newspapers. So, that was something interesting, and look, to be honest, I wasn't until the last year of my PhD I decided, I want to try and go into a full-time role in academia, and I was successful in getting into Macquarie Uni as a full-time staff member after my PhD, and I was there for almost 3 years, and it was a great team, but from a personal perspective, there was a sea change looming for my family and I, a young family, and we moved up to the Sunshine Coast, which is north of Brisbane in Queensland, and at the same time there's an opportunity to join CQU, Central Queensland Uni, and I was successful, and now I've been there just over 2 years as a senior lecturer, and again, like Macquarie, this is a really great course there, a great team, and great opportunities for research. So, yeah, I guess, Dean, that's been my path.
Well, Matt, what a cool journey. Really great team. You've surrounded yourself with excellent mentors. And, that I do remember that study that you were talking about with the relationship with back pain and heart disease. And that generated definitely a lot of attention. And there's some really interesting relationships there. There's no doubt. Back pain and almost any comorbidity, essentially, it seems like. If you could tell us, now that you're at CQU, what does your typical day look like?
Yeah, so at CQU, I teach in the master's program, so the 4th and 5th years. In the 4th year program, I assist with spinal skills and neuro classes, and I lead the peripheral skills classes, or the extra spinals as it's called, which has an element of orthopedics in it as well. And in the 5th year, or the final year, I teach pediatrics and pregnancy, and also sports medicine. So in that final year, we try to provide a bit of a wholesome experience for the students. So we encourage them to go out and observe these specialist practitioners in their clinics. We also bring in specialist clinicians in the fields of peds, pregnancy, and sports medicine, so they conduct specific 4-hour workshops for our students. And also this year I started to interview via a podcast for these specialist clinicians as well. So there'd be 30-minute chats, if you like, on topics like pregnancy and pediatric sports medicine. And this was for the benefit of our students, in addition to delivering the traditional lectures and tutorials. And there we really try and focus on implementing some contemporary research that's out there for these topics. So that's my teaching. For research, we have students, as you mentioned at the start, we have MRes students. We've got students exploring fascinating topics like behavioural change, also chiropractic in the older population. And we've received some funding to explore the experiences of patients who consult spinal surgeons, but they're discharged on their consultation or dismissed, and they're considered a non-surgical candidate. And we know from experience that these patients have been on wait lists for a long time. Their expectation is that they have a structural problem, and therefore this can only be fixed through surgery. So we want to know how they feel when they're discharged and dismissed. So we probably get a sense of how they feel because they sort of re-enter the system, and they end up having a second opinion or so forth. But we've also got some money to look at some qualitative work to look at the experiences of patients and chiropractors with respect to physical activity promotion. And also, I'm interested in swimming, as I mentioned at the start, so I'm keen to explore swimming and low back pain care, whether it's more prevention or more from a self-management perspective. To my knowledge, there's only one trial that's looked at this, which is somewhat surprising given the benefits of swimming and health. And I do a little bit of clinic too as well now. I've just re-engaged in the practice a tiny bit. I had a few years off during COVID, obviously moving into state, but I think, Dean, you can relate to this as everyone else can, is that as chiropractors, we have a tremendous set of skills, particularly with our hands and our knowledge, and we from time to time get a really amazing results with our patients, and we make such an impact on their lives that, to me it seems almost silly that I would give that up. So I'm glad I'm sort of practicing a little bit too as well.
Yeah, 100% agree. And, I have to think, at least for myself, that the interactions with patients guide the research in some degree. They just keep you curious. And honestly, they just generate so many questions. I get so many questions after an encounter that, I try to write them down sometimes. But It just keeps going, right? It's like it's a nice circle of experience, practice, research, and it all comes around. So
It does. And as you say, you get asked questions that stumps us. Sometimes we don't have the answers, but I often say, you know what, it's okay. I don't know the answer, but I'll find out for you. I'll do my best to find out.
absolutely, yeah, I love that. Well, Matt, we're going to be talking about physical activity and exercise. Again, two things we're pretty passionate about. You've conducted some really interesting research as it relates to physical activity and exercise. I think essentially more than anybody in the profession, and so I'm keen to get your ideas about what's going on in the profession, exercise wise and physical activity wise, and what I figure we could do is we could talk about a few of your articles, and then we could use those articles as sort of a baseline or a springboard, if you will, for a general conversation about physical activity and how that relates to chiropractic practice. So without further ado, maybe we should just get into our first article, and this would be titled "The Prevalence and Determinants of Physical Activity Promotion by Australian Chiropractors, a Cross-Sectional Study." This was in Complementary Therapies and Medicine, and this was 2019. So if you could walk us through that paper, that'd be great.
Sure. So prior to this paper, I guess as you mentioned, there wasn't a great deal to go from in regards to physical activity in chiropractic. So we do know chiropractors are trained, educated in diagnosis and management in a broad range of musculoskeletal conditions. We're known as spine doctors or experts, but also chiropractors are broadly recognised as well as advocates for active lifestyle, general wellness and health promotion. And the limited literature that was out there prior to some of the studies that we conducted showed that at least 90% of chiropractors were prescribing or advising on physical activity or exercise, particularly in their consultations. But much more than that, we didn't know. So, we looked at this study that you've described in Complementary Therapies and Medicine, and just a bit of background to this study. This was part of the Australian Chiropractic Network Research Network, or the ACORN project, and this was a national practice-based study for chiropractic that was launched in around 2015, I think. And so a lot of effort came in, and it was sponsored by the ACA or CAA at the time, and they managed to capture responses to a survey of more than 2,000 Australian chiropractors, and we looked at a secondary analysis of this data so we could target physical activity. And we really focus on the practitioner characteristics, their practice settings, and their clinical management characteristics as it related to physical activity. And obviously to do this, we utilize some regression analyses to identify factors that, strongly associate with practitioners who would frequently discuss physical activity with their patients. And I can go through some of the results, but they won't be surprising. For example, we found that chiropractors that frequently discussed physical activity were at least 6 times more likely to talk about OH&S, or occupational health and safety, at least 3 times likely to discuss diet and nutrition, 4 times more likely to discuss substance abuse, including smoking and alcohol and drugs, 4 times more likely to be engaging in injury prevention, exercise therapy, rehab, including taping, and twice as likely to be caring for athletes and sports people. So, as I mentioned, all of these relate together and are not surprising, but at least to us, as per any secondary analysis, it does sort of pave the way to look at further research questions and give us a chance to maybe evaluate the role and the contribution that chiropractors are making in this, I guess, really important public health topic. So, yeah, in a nutshell, that's some of the findings from that paper.
Yeah, it seems that if I had to generalize it, and you can correct me if you think otherwise, but it seems to me that the chiropractors who are generally promoting or discussing exercise are also promoting other health-related issues, trying to just promote public health in general. Do you think that would be accurate?
I would tend to agree. I think given that the relationships are strong from the odds of, doing one thing or the odds of likely to do something very related. Yeah, absolutely. I think that we would definitely, expand the discussion and move into other related topics, as you mentioned. Yeah, for sure. It's genuine assumption.
Yeah. So let's do that then. Let's talk about just physical activity. I guess in general, perhaps we could talk about physical activity guidelines. Just give some thoughts to chiropractors who may be interested in incorporating exercise or just simply want to have, they just want to listen to a discussion about people who, study exercise and do research in this area, talk about, what is it happening in practice these days with exercise? So maybe we could start with that, physical activity guidelines, and then we can just work our way through some of these issues.
Sure. So the guidelines, as we know it, generally people will talk to 150 minutes per week of moderate or maybe, 75 minutes of more vigorous physical activity per week. And just some context with the guidelines, they seem to be updated every 10 years. So people might remember the 2010 guidelines, and we're currently working with the 2020 guidelines. And the WHO, World Health Organization, and particular researchers and stakeholders in the area will probably meet in 2027 to prepare the guidelines for 2030. So they'll look at all the relevant research. But the narrative hasn't changed too much, but there are some interesting additions to the 2020 guidelines which will be of benefit. And the first is that they recommend physical activity more so across the lifespan. So there's specific recommendations to children and adolescents, obviously our working age adults, but importantly too, they move on to recommendations for older adults as well. Another aspect that's important is that they include people with disabilities, people that have chronic diseases, and pregnant women and postpartum women too as well, because the latter three, when they hit the transition point in their lives, be it chronic disease, disability, or postpartum, there's an element there which may see a person somewhat retire from physical activity given the transition and the elements that go with it. And they may not necessarily re-engage with activity. So they're important populations or subpopulations. The 2020 guidelines also made special mention towards the benefits of activity with regards to mental health, so in particular depression and anxiety, but also the importance of staying active for good cognitive function. They also took time to talk about sedentary behaviour, so we can have the good and not so good behaviour. Good behaviour would be things like, and this is targeting children more so, things like doing homework and reading. And the not so good is the technology of excess screen time, tablets, phones, etc. A final thing that the guidelines did too as well is they removed the 10-minute continuous activity. That was dropped from the guidelines because more recent research sort of showed that you could reach a lower threshold and get benefits from physical activity. So you could do things for 30, 60 seconds, for instance. And a lot of this has come about through device-based measurements, so the use of actigraphs or accelerometry-based instruments. So they were able to highlight a number of different areas where our traditional self-reported information that the guidelines are derived from couldn't really measure. So, yeah, there's some of the key things, I think, at least for a chiropractor, that we could take home in regards to the guidelines.
Yeah, absolutely. And, you mentioned the sort of sensor technology-based way to assess physical activity. I can't tell you how many times patients of mine come in and, they're wearing a Fitbit and they say, "Doc, let me show you what I've got for the week." And I mean, some of these watches have heart rate variability and they tell you about your sleep. And I mean, it's some pretty fascinating technology on there. And, I would certainly encourage it. I want to mention one other thing too. You said the change in the guidelines from, trying to achieve at least 10 minutes. And now it's basically fluctuating to just, get any activity. Any activity is better than no activity or less activity. So I think that is a great shift. And I have to say that saying something like that versus, try to do 150 minutes to somebody who's not particularly active is a much easier go.
It's a better sell, isn't it?
It's a
It's
much
more
better
likely
sell.
to be feasible and achievable too, as well. And as we know, we look at musculoskeletal conditions all the time, and that's a big barrier to exercise. So yeah, anything that can be done, and as you say, dropping that 10-minute threshold has been a big thing.
Yeah, totally. And I know, as we were talking before today, we just, we had a conversation before, and you mentioned about incidental activity even, and how that can add up over time. Why don't you just tell us what you mean by that?
Yeah, sure. So this is coming off the back of the devices that we just had a chat about there. And the thing about devices is it can actually pick up various intensities or bouts of exercise, whereas our traditional questionnaires can't necessarily or don't necessarily pick this up. And when we talk about incidental activity, we talk about 3 to 5 bouts of vigorous activity, if you like, that occur as a consequence of what we do in our daily lives. And for example, it might be engaging in 15, 30, 45, 60 seconds of activity throughout the day. It might be things like sprinting to catch a bus or to catch a train. You might be on the trampoline playing with children for a couple of minutes, getting the heart rate up. It may be something that challenges the muscular system, for instance, carrying groceries to the car. It might be a long walk back to the car park. And if you do a couple of these things during the day, particularly as you mentioned before, for the non-exerciser, someone who has musculoskeletal problems, this can really work for them. And the research is at least showing that there are potential benefits of doing this incidental activity that can be quite equivalent to what the gains are with respect to vigorous activity or guideline recommendations. So there's certainly emerging research that shows that you can get benefits from things that are just happening incidentally, things that are not planned, and therefore, if you're doing them as part of your daily life, it's very feasible to do maybe a few more.
Yeah, absolutely. And yeah, I wanted to just clarify a couple of terms that I've used just again for clarity. We sometimes throw around these terms exercise and physical activity. I'm not sure that everybody knows that there is a difference between them, at least the way researchers talk. So I just want to clarify that physical activity basically is any type of body movement where your muscles are doing work and moving you around. But exercise is more of a planned activity. It's structured, and I'm going to go out and do a walk, for my health type of thing. And the idea there is to maintain your physical fitness. So just wanted to throw that out there because I know sometimes we use these terms and they should be defined because there is a bit of a difference. Okay, how about strength training? How do you think about that in relationship to what we were talking about, guidelines?
So strength training is interesting, and it's definitely part of the guidelines. It's very critical. I think as we get older, it's obviously very important for our older population that we enter a field of osteoporosis and muscle mass loss or sarcopenia. But the guidelines are consistent and recommend at least 2 sessions of strength training or resistance training a week. And I think from a patient perspective, it's what's most convenient. And we know what's convenient is to be using body weight, your own body weight, for example. And to be honest, I think if you combine this with the aerobic activity recommendations, I think both of them together are probably best, to be honest.
Yeah, totally. And we'd also, prior to today, talked a little bit about some of the other benefits of exercise. And you actually threw out a few that I wasn't particularly thinking about, or I don't, necessarily think about all the time. And those were recovery and regeneration issues. Normally I would think about, maximizing tissue tolerance and that sort of thing through exercise, maybe maximizing performance, but maybe you could just speak for a few seconds about the recovery and regeneration ideas.
Yeah, I mean, I think it's almost like a reward for doing your activity, and I think a lot of this depends on who's in front of you. If you've got that elite athlete or semi-professional athlete, weekend warrior versus someone who has musculoskeletal pain, I think for the first, if we're looking at athletes or sports participants, they have great exposure in general to recovery aids, and we're familiar with many of them, from compression gear to massage therapy and ice baths, which is quite topical these days. But we know that sleep is probably the best in this instance. And then, on the other side of the coin, you've got our musculoskeletal patients, people that we're more likely to see. And to them, it might be totally different. It's more a case of, getting them active and moving. And before we start thinking of that recovery, regeneration, restoration aspects, it's more about maybe gradually exposing them to what they see as fearful tasks. So, we want to engage activity in a really non-threatening, or perhaps in a very safe environment. So, I sort of feel as though we need to jump that hurdle first before we introduce them in the recovery. But, we naturally would use these regeneration elements as part of our care anyway, if you think about it, don't you?
Absolutely. Oh, yeah, no doubt. And everybody's got a bit of a progression. I mean, if they come in acutely, certainly we can't do the performance issues. We got to get through the basic elements, get to facilitate the range of motion, make sure there's stability, those sorts of things before we can really progress. And speaking about progressing through exercise, I wouldn't mind at some point during our discussion talking about the FIT principle, or just how we manipulate exercise to achieve the type of performance that we're looking for, whether it's to try to alleviate pain from a musculoskeletal standpoint, or to maximize performance or recovery or any of these other goals. But I almost wonder, maybe we should talk about that coming up, because I think we're going to be getting into more of the clinical issues after we talk about this next paper. So why don't we do that? Let's talk about this next paper. And this is one that just came out just a few months ago, actually. And this is Physical Activity Promotion in Chiropractic, a systematic review of clinician-based surveys. And this was in Chiropractic and Manual Therapies. So I wonder if you could walk us through this paper.
Sure. So this was a review that we decided to just include surveys. And in the end, we found 15 surveys all up that were relevant to physical activity in chiropractic. And collectively, that included almost 8,000 chiropractors. A past review sort of looked at this question, not to the depth that we looked at it, and we end up finding 5 times more the number of articles compared to that previous review. Up front, as you know, Dean, it's important to assess any paper for its quality, and certainly we had some methodological quality issues in that we lacked a high number of high-quality studies. And the weaknesses from the questionnaires often came from missing data, small numbers, so we had non-representative samples, and with small numbers, there was low response rates. So this, had the capacity to, challenge the certainty of the results that we find. But in saying that we did find some results that probably won't surprise people again. I think that we sort of broke down the questionnaires and broke them down into different themes where they best fit. And we found that, almost 100% of chiropractors saw physical activity information or counselling or discussion as important. More than 90% of chiropractors were prepared to provide physical activity or exercise information, or possibly counsel patients. Up to 97% frequently obtained physical activity information from their patients. I mean, what they asked, we're not sure, but they looked to extract information, probably asking them about how active they were. Almost 100% frequently discussed or provided physical activity information for their patients. But when it came to counselling directly, around 50 to 81% of chiropractors did this with this patient. And I do acknowledge in this paper, the lines may be a little bit blurred when it comes to discussing physical activity versus counselling for physical activity. And I think, at least to me, the counselling aspect was more in relation to a clinician mentoring the patient, spending more time talking about the particular topic, and possibly looking at action planning. So the clinician leads the way and shows the patient what they should do, why they should do it, where they should do it, how they should do it. So they took on a coaching role, whereas the discussion of chiropractic and physical activity with patients was more about, just simply, chatting about it. So, in a nutshell, that was the elements that we found in regards to that paper.
Okay, great. Well, from that, and I'll just mention that here in North America, I think the last survey that I'm familiar with indicated that a little over 90% of chiropractors incorporate physical activity in some way, either again through counseling or recommending physical activity in some shape or form or another. So I think that's really interesting, and it just seems like most chiropractors are interested in lifestyle, are interested in promoting the overall health of their patients and trying to incorporate many ways to do that. So I think it's converging evidence in my mind. Certainly, we could always, use better quality studies, but that the data does seem to be converging on that. And I guess the question in my mind is, what is it exactly that chiropractors do in their practices? I mean, I know what I do, you know what you do, but do we have a sense really for how often chiropractors discuss physical activity? Like, is it on a daily visit, or each visit basis, or is it like on re-exams or whatever you want to call it, reassessments? Just curious what your thoughts are on that.
Yeah, that's a good one. I think the answer off the top of my head is I don't know, because obviously I can only vouch for my clinical experience and what I discuss with patients. And I think more to the point, we make the recommendation in the paper that we should consider physical activity as a vital sign. We should be asking about it at each consultation. We should be, if we're not asking, we should start asking about it. And if we're not comfortable, we should utilize small validated questionnaires, for instance, that are available that might take 60 seconds to complete, and then that'll put you into one of four categories, from not being active to being sufficiently active, and that gives you the opportunity to start the conversation too as well. So we currently, actually related to the question, I guess we currently have a paper that's in review where we surveyed Australian chiropractors, and we tried to dig in a little bit deeper to look at the management characteristics and see if we could tease out things like that. And I don't think we could tease out exactly the sort of things that you're after, but we certainly found some interesting factors, and happy to elaborate with that if you like.
Yeah, love it.
We found that when we looked at the management characteristics of Australian chiropractors, they were not surprisingly likely to treat working age adults, but also it closely followed older people, 65 years and over, and also likely to manage athletes and sports people. So you would think if we're constantly seeing these types of patient presentations, you'd like to think, based on the percentages we spoke about earlier, that they are receiving some form of physical activity information. But within our study, we did find some interesting results in relation to pregnancy and our youth populations. So when we ran our regression analysis again, we found that Australian chiropractors who were more likely to promote physical activity were actually 50% less likely to discuss physical activity in a number of subpopulations. And that included pregnancy and postpartum women, and also youth, so our children and our adolescents. And this is somewhat concerning, I would think, and it probably highlights that a chiropractor may not have a good knowledge base of the guidelines. They're confident in talking about physical activity, and that may come off the back of them being physically active themselves, and we found a high percentage of chiropractors were very physically active. But when we tested them about their knowledge base of the guidelines, at least in Australia, 1 in 3 were not at all familiar with the guidelines. And this was consistent with other healthcare providers, including podiatry and nursing, physiotherapists too as well, not only in Australia but also overseas in America and in the UK. But back to our survey and the fact that chiropractors who were promoting physical activity were less likely to promote to the youth and also pregnant patients. To the youth was critical, because we know sedentary behaviour is an enormous issue. But to our pregnant and postpartum women, it also raises a possibility that chiropractors are providing no information in regards to physical activity because maybe they're not confident to do so. And worse still, misinformation. For example, you might get advice that we know is not true, such as don't do exercise because it could harm you and it could harm the baby. So certainly it was quite eye-opening, some of the results, whereas other results, provide a straightforward answer, and it's like, well, that seemed obvious and that was expected. So interesting.
Totally interesting. I want to follow up on a couple of things. One is I think it was really key thing that you said about treating the physical activity as an opportunity. What a perfect way to say that. And I hope this conversation that we're having now opens up some of that opportunity for chiropractors in practice to explore these issues, such important issues with their own patients, their own populations. The second part was an opportunity to dispel, let's say, misinformation or myths, like with the youth. I mean, sometimes I get questions such as, if my child strength trains, are they going to stunt their growth? I mean, there are so many interesting, strange questions that we all have, and with that one, there just really isn't any evidence that it's going to stunt your growth. Although I can't point to any that it's going to make your growth that much better either. But well-supervised strength training in children is a safe activity. And, the same thing goes for other subpopulations like the elderly. I mean, within your clinical reason, strength training the elderly is another population or subpopulation that, really needs the exercise, especially if they're frail. So anyways, I just wanted to throw that out there as well.
Very critical. You're spot on.
So, Matt, with the research that you're doing now, I don't know if you can answer this or not, but I'm going to ask it anyways. What do we know about the actual types of physical activity that is being prescribed? Is it more, do you think, physical activity for promotion of health, or do you think it is more therapeutic exercise targeted at a condition like back pain or neck pain or elbow pain or something like that?
I think at a stab, I think it's both. It's a combination of both. But again, I can look back to our paper that's in review and I can talk to Australian chiropractors. And what we found was somewhat surprising because, aerobic activity is the headline act, if you like, when it comes to the guidelines. And then we sort of, work our way through and we find resistance training as well. But for Australian chiropractors, we found that resistance training was the more likely one to be prescribed rather than aerobic activity. And to me, this seems somewhat logical if we move away from the gyms because we can just go back to using one's body weight for resistance. The other thing that was quite popular too was flexibility, for instance, prescribing stretches, and also balance was a big one as well. But to your question, I think, as I mentioned before, it is a blend of both exercise, which, you define that as structured and prescribed, and also just being mobile and being active. The other thing, too, that we found in our results is that we found our Australian chiropractors were actually quite aware of community-based programs. So things like Tai Chi classes, dance programs, walking groups in particular, and other health coaching aspects. I do know there's a Get Healthy program that's available, and also we know private health funds also provide these opportunities for their members. But, I'm not really sure if it is more so for that rehab goal, if you like, that you sort of asked, or is it more for that general health as per, the question. We also don't know what sort of referral relationships chiropractors have there as well. So, I sort of feel like there's elements there that we've kind of answered, but, as always is the case, there's more questions than answers.
Yeah, well, I can say that I'm really pleased actually to hear that the chiropractors in your survey seem to have a pretty wide network. They knew where to refer people. They knew what was going on. terms of physical activity. That's excellent to hear. It's exciting when I don't know. I just love to hear that because
It's
again,
positive. It's positive for us.
yeah, it's totally positive. It's amazing. Well, Matt, let's get into the last article here, and this is again another interesting study, one that I've heard a lot about. I honestly don't know a whole lot about it. I haven't read too many of the papers on it, so I'm interested in hear you speak about it. And it's the GLAD program. This is called GLAD Back Australia, Mixed Methods Feasibility Study for Implementation. So could you tell us about this GLAD program and this feasibility study?
Yeah, sure. Happy to. Particularly, as you say, not too well versed in it. I'm happy to expand in regards to this program. So GLAD Back is an education and structured exercise program for low back pain, and it was born or came about as part of the hip and knee osteoarthritis program that originated in Denmark. Importantly for us, this was a feasibility study of implementation in the Australian context. So we wanted to see whether it would work here like it had in Denmark, where it originated from, but also in Canada, where Professor Greg Korchok had led that study as well. So from our end, the results in Australia, generally our study appeared feasible to implement. Of the 20 clinicians that we trained, half of them went on to offer the program to their patients. And we had significant complications because that was during the first of a couple of COVID lockdowns that we had in Australia. And so our clinicians quickly moved to telehealth. And to be honest, to move that swiftly, I thought it was fairly successful in the way it was delivered on that part. But naturally, we did lose some patients too, because they were enjoying the social aspect and somewhat motivational, competitive aspect of coming together and exercising together, and then they were reduced to going to their living room or bedroom and doing exercise via a camera from their phone or from the computer. But we found that obviously the COVID pandemic there impacted our retention of patients and therefore impacted our data collection. But we did find some interesting things. The first one was that the physiotherapists fared much better than the chiropractors, and we put that down to physiotherapists having experience with the GLAD program, the original hip and knee program. So it seemed as though they had the systems in place in their clinics to easily transition to online, whereas with chiropractors it was a little bit new and probably somewhat different to their practice management, the way their clinics work. The second thing, which was interesting too, was more of our secondary outcomes, and we looked at some of the patient-related outcomes, and we're very cautious to report these back because we only had a certain number of patients and we had a larger dropout due to COVID. But we did see potential improvements, and one of the big ones was in the fear avoidance behaviour. And we found a strong reduction there, and I think this came back to the education aspect of GLAD Back, which seemed to work really well, and I'm happy to expand on that in a second. But we also found from a physical component, we found that the endurance test that we started at baseline, so we looked at the isometric low back extensor test and also the isometric trunk flexor test. And, Dean, you're familiar with these tests where you would hold them for 2 or 3 minutes and see how long a patient can sustain that isometric hold. We found that after the GLAD Back program, a lot of our patients actually doubled their isometric time. So that was important. So I'm happy to talk more about it if you like, obviously, because obviously I think the exercise and the education in particular is really topical right now too as well. And I think chiropractors can benefit. So...
Yeah, I'd be particularly interested, Matt, if you could just very briefly describe the components of the program. So I gather it's supervised with, in this case, either a chiropractor or a physiotherapist, and they're guiding people through this program. So I imagine that it would involve components of flexibility, strength training, perhaps with body weight or implements. And because they did so well in the isometric holds, I imagine there's got to be some core, spinal stabilization kind of training as well.
Yeah, definitely. Sure, I'll elaborate on those for sure. So look, GLAD Back actually came about, to put into context, it's because our low back pain guidelines or recommendations are generally not routinely implemented well. And if you read some of the research, it's possible that if we're not implementing these guidelines from high-quality studies, then we may be leading to huge treatment variability for our patients, potential wasted resources, and potential harms. And when it comes to the harms, I think we relate back to the overuse of imaging or use of scanning, the overuse of surgery for back pain, and the overuse of medication, in particular opioids. But important too with the guidelines was a failure to provide education and advice. And when it came to Gladbach, their aims were really to try and translate these guideline recommendations into a practitioner-delivered program that was evidence-based and had the goal of providing self-management support. So a lot of it obviously initially is led by the clinician, and it was important for the clinician to impart knowledge so patients made really good decisions. And critical to this was educating patients about low back pain. And ultimately that would lead to more confidence from a patient perspective, trying to change their beliefs and fears. Also critical from the clinician was that they provide pain coping tools. And it was important for clinicians to talk about more recent work on the trajectories of low back pain. And we're familiar with that, once you get it, it doesn't necessarily go away. But important for the Gladbach participants, it was that we talked about the inevitability of having a flare-up of our lower back pain, and for patients to expect it and not fear it, and tackle it head-on and find ways in which they could manage it. Another element that was important from a clinician perspective, at least to lead it initially, was that the goal setting was really critical for patients. So the goals were very much patient-based, and what we found was that patients generally wanted to be more active. They wanted to have better tolerance of their pain in regards to being in the workplace. It would positively impact their relationships, better sleep, better energy, and just generally coping well with pain. And this was interesting because if we look at our clinician goals, we're going to look at what we were taught. And, that was, to improve range of motion, better alignment, better posture, greater strength, reduction of pain intensity. So at least to me, I found the education aspect to be critical as a starting point for the exercises, but also it was critical because it's probably where we might have our greatest weakness, where we put our chiropractors out of their comfort zone and start to educate and talk about, these aspects to try and improve patients' knowledge and understanding, improve their confidence, reduce their fear. So with that, I think it's important to maybe just elaborate a little bit on the educational aspects, because I think the listeners will find this useful. And Gladbach really just talked about 8 key messages, and we can really summarize them in 4 key points. The first one was that you need to be telling your patients that they have the skill set to be physically active and exercise, and the important thing is that they can move with variation. So if they're faced with difficulty with a particular movement while performing an exercise or painful task, they shouldn't give up or stop and be fearful of it, but rather find a way around it. The other point was there's an emphasis on the pain physiology or the pain neuroscience, if you like. And despite people having fear, we want them to still move because we know the body can adapt. It's really bioplastic, if you like. And we bring the brain aspect into this as well, and we talk about the brain having the capacity to maybe turn pain up and down, a bit like volume control. And that pain is more an alarm, not harm, and definitely that pain doesn't mean tissue damage. And so, and Greg Korchak often talked about, pain being like an annoying song in your head that you just can't get rid of, and I know we've all had that experience. The other important aspect with the education or the key messages was that often, patients will present with scans that show some sort of deformation, typically a scoliosis or a kyphosis, for example, and patients will see these and automatically feel as though the pain is originating from here. But we know, of course, that we don't necessarily know that the pain comes from these deformations, and we can definitely be active despite what we see on a scan. And I think the last message was just being active, that reassuring your patients that their back is strong, robust, and made for movement. And that, some of the messages were, action comes before improvement. Action may inhibit pain, and movement is part of the cure, not the cure. So when it came to the exercises, you had this foundation, which was really important. So that would facilitate exercise engagement. And as you mentioned before, Dean, you were talking about the improvements in the isometric tests and the likelihood of there being core exercises. Well, that is true. And to be honest, people, when they see, at least when we ran the course in Australia, people were sort of, left somewhat stunned, if you like, because when they saw the exercises, they realized it wasn't rocket science and the likelihood of them doing 90% of them already. And as you mentioned, a lot of it was body weight, and the most equipment that you needed, I think, was just the TheraBand. But the important aspect was that it was supervised in a group setting. So the clinician, again, had a critical role here, because when a patient was engaging in the exercises, they provided problem-solving skills. And that was basically, as I mentioned before, if something was a roadblock or hurting, try a new way, explore a new way, find a variation. Don't worry about having a perfect technique. That sort of went out the window and wasn't emphasized. The other one was to, provide it in a group setting, which was so important prior to COVID, because the group setting was motivational and inspiring, particularly if you saw someone who looked somewhat crook or not well in regards to their back pain. They were still trying, and so if they could do it, you could do it. And so this would challenge and potentially change their illness beliefs, such as fear avoidance, and also improve that self-efficacy, where they would continue to do the exercises from their workbooks. They had different levels, and they would progress, and they would talk individually with the clinician who was supervising and try and build their capacity. It might mean moving to the next exercise, which was a bit more difficult, or adding more repetitions to that exercise just to build that capacity and at the same time reduce pain. So I guess in summary, when it came to the exercise delivery, it wasn't about correcting the wrong performance, and perfect technique was not a conversation that was had. In fact, technique was not raised at all. It was important to integrate all the educational aspects that I spoke to earlier in every exercise session. As I mentioned prior, the exercise variation was key, but important, the clinician, when the person did the exercise, the clinician really focused on two things. The first was that when they did an exercise like the 4-point kneeling, the bird dog for the lower back, the clinician really made a point to tell the patient that you should be feeling this in your lower back and maybe feeling it in your buttocks, for instance. And also, it was important for the clinician to transition into a coach, and that is to provide motivation and build the confidence, and that came from the clinician. So you were just encouraging the patients all the time. I guess the last part of GLAD was that the clinicians were responsible to document the treatment effects and capture information from the patients. So basically you could collect data for research later on. So I guess that was a bit long, but hopefully it gives a really good rundown on what GLAD back is.
Oh, definitely. I actually really appreciate you going through it in that level of detail, because I really get a good sense for how these chiropractors and physios were actually, dealing with these individuals or in groups, I suppose too, and how they were coordinating sessions and working with the variability, as you said. And I guess I hear that and I think, well, this sounds like a really positive, intervention in the sense that, again, it provides an opportunity. It's just another opportunity to get people better, with the focus being positive. Do what you can, change, vary up. If you can't do this, do it this way. The point is to get them to be able to do things, we'll say, movements, skills, that they can. And so I really like the focus on the positive. I like I said before, I really didn't have a great sense for what GLAD was, but I'm really intrigued, and it sounds like an awesome program from what you mentioned. So again, thanks for going through that. That was awesome.
No problem. It's good.
Yeah. So, you mentioned guidelines. So I do want to talk about that, because inevitably every low back pain guideline that comes out these days seems to talk about, first line, second line, third line types of therapies, or, professions that may be able to contribute to to people's back issues. And, ones that keep coming up would be manual therapy, sometimes just explicitly mentioned as spinal manipulation. Others, education, cognitive behavioral therapy. I mean, there's a lot of interventions. You mentioned, there should be less focus on the medications, et cetera. But I want to focus in specifically about the manual therapy and physical activity, since chiropractors, do hands-on care typically, and they, as we've just talked about this whole time, they do physical activity as well. They're motivating people, they're engaging them in physical activity. So I guess my thought was, do they go together? And it's just obvious that obviously they do go together. Should they go together, and how much should they go together? I guess maybe the better question.
Yeah, look, I agree. Definitely they do go together. I mean, if we think manual therapy, and as you alluded to correctly, they do often specify spinal manipulative therapy. And, that's what a chiropractor does. That, they look at their adjustments. And if we think purely chiropractic, we know that their main tool of choice is going to be the adjustment or the manipulation. And if we look at the aims of those, obviously there's neurophysiological reflex changes that we get, but also there's movement that we're getting from the joints. And, physical activity is movement as well. So, they're both part of high-quality recommendations for guidelines too, because as you mentioned, there are lots of guidelines out there, and not necessarily all of them are of high quality. But thankfully for us, we've had people wade through all the guidelines and made recommendations for the high-quality ones, and be happy to know that manual therapy is in there. But typically it's not in there in isolation. It's in there as an adjunct to all the others that you mentioned, including advice and reassurance and exercise too as well. The other thing too, which just reminded me now, and based on your question, was I remember years ago I talked to a credentialed McKenzie therapist, and we know with McKenzie or mechanical diagnosis and therapy, very much a hands-off type care. And I remember the McKenzie therapist was talking at a chiropractic conference and said, chiros and McKenzie therapists are closer than you think, because the McKenzie assessment and subsequent treatment prescription, particularly if you're looking at this derangement, often occurs at that end range. And, he went on to say that, manipulation sort of works in this space as well, at that end range when you're adjusting the spine. So, look, I agree with you wholeheartedly that they do go together, and they should go together. Gotcha.
Well, we've talked about, what we think chiropractors may be doing in their visits, that we know that a lot of chiropractors are doing, physical activity and some forms of exercise in their practice. But the people that maybe are not utilizing it to its optimal potential, or people that chiropractors that may not be incorporating it at all or very little in their practice, what do you think some barriers might be for chiropractors to incorporate physical activity and exercise into their practices?
Yeah, so again, our results, Australian chiropractors, resonated a lot with other healthcare providers when we searched the literature. And the first barrier that chiropractors have is time. So not having time to sit down and talk about maybe physical activity, planning, programming, or even just alluding to the guidelines. A second one is reimbursement. It's a very close second. So chiropractors are not getting paid for it, that extra time that they need to, need to be covered for. And also another reason, which was somewhat surprising, is that some chiropractors, had some doubts that talking or discussing physical activity won't actually work, because they weren't convinced that there would be any behavior change associated with that. So I found that one interesting as well. That was that was in the top three.
That's fascinating. I guess, it actually baffles me a little bit, given that we do so much education, it seems, as a profession, just, telling people about their condition and trying to be positive and emphasizing, like what you said, the variability and movement. And there's so many opportunities. I really like that as a theme for our discussion today. But I suppose you're right. And just having maybe some unfamiliarity with an area would, I guess, naturally lead one to probably not talk about it or recommend it as much.
That's true. I mean, when you talk about unfamiliarity, we're talking about the guidelines. And I mentioned before in our results, 1 in 3 Australian chiropractors were not at all familiar with the guidelines. And this, again, was consistent with other healthcare providers, including physiotherapists and including general practitioners or medical doctors, our podiatrists, and also occupational therapists and dentists and nurses as well. So they may know a little bit about it, but in terms of some specific recommendation or a prescription, there's 30% there that are not familiar at all.
Fascinating. Well, Matt, how about could you tell us about people who are listening to the podcast? They might be interested. Hopefully, they're interested in possibly getting involved in research in some way, whether it's writing up a case study or maybe a review article or what have you. Can you provide any advice to these chiropractors or students about how they may wish to become researchers, or maybe get them on that track? Like anything motivational for them would be awesome.
Yeah, so I think we're all inquisitive in nature, and obviously we're all really curious, and we've always got these questions that roam around our heads, particularly in the clinic. And I guess we've all been to research symposiums, and we know at the end of a particular presentation there's always time for questions. And we often find that questions from the audience are often amazing and very thought-provoking. And typically the speaker may not have the answer and often resonate with the answer that goes along the lines that research hasn't been done. So if you do have those questions, I think look to take that next step and maybe do something small about it to start with. Maybe reach out to the researchers that are out there that you're familiar with and have a conversation. I know they'll be open to a conversation. And, if you're not a fit for whatever reason, I know the researchers will at least point you in the right direction. But I think for the person engaging in the research themselves, I think there's lots to be gained. And the first is you can make a difference and a contribution to a particular research area or to your profession. And, it can be as simple as collecting a bit of data and then going on to tell the story, if you like. There's certainly positives in terms of career advancement. And, if you engage in a, MRes or a PhD of sorts, then, there's opportunities to travel abroad, to go to conferences abroad, but also to go to other research institutions and do some time there, which was something that I did and was really impactful. But it was more impactful when I got back home and realized how amazing that experience was. And, the other thing is, too, that you can become a leader somewhat in the field or in the particular topic. And I think a lot of clinicians may be silently sort of sitting there and reaching the point in their careers, too, when, they realize that things are becoming a little bit repetitive, if you like, and they probably want to mix it up and not sure how. And, they can deviate slightly and be inspired to remain in the profession by contributing to research. So, research becomes an option for them. And I think personally, and Dean, to yourself, it's a rewarding option too as well. So I guess the answer there, at least my advice, is to reach out, throw your idea out there. We are more than happy to have a chat. And also my last point would be that if you, maybe check with the researcher and see what they've got on offer too as well. So see what their team is doing, see what their funds are currently covering, and see if that resonates with you and try and go from there. So, yeah, that would be my advice.
Well, that's fantastic advice. Really excellent. Well, I tell you what, Dr. Fernandez, this was just a really fun conversation. I'm inspired to do a lot more exercise next day in the clinic here. So you got me pumped up.
It usually happens.
So, hey, thanks very much for coming on the podcast. Like I said, this has been a great conversation. I really appreciate what you do, in the profession, for the profession, and really excited to hear all the great stuff that you're doing, and really grateful that you were able to come on and tell the rest of us, what it is you are doing, and explain all of the great research and the GLAD program and just all of it, the guidelines. I mean, there are so many, I think, great points that you brought up that, again, just very thankful.
Thank you, Dean. It's been an absolute pleasure to be on your show and also to have the opportunity to elaborate on topics that, we're both really interested in. So cheers.
Awesome. Bye for now. Well, that was a great interview with Dr. Matt Fernandez. Stay tuned for more great interviews coming up.